Hi, everyone. Thanks again for joining. I am pleased to introduce Eleanor Perfetto, our Senior Vice President of Strategic Initiatives here at the NHC, and I'll kick it over to her to start the webinar.
Good afternoon, everyone. Thanks for joining us on Valentine's Day. We think you're going to really love this program. Ha ha. It will be the only corny joke that you'll get this afternoon. So we're going to be talking about alternative payment models, and this is our second in a series. We have 3 sessions going on alternative payment models. This is the second one. If you joined us the first time, we covered in that one a high-level overview of alternative payment models, and we talked a little bit about why is this happening right now, what kind of environment do we have right now that would have brought about the change to alternative payment models. Today, we're going to get more of an introduction specifically into the payment models themselves, some of the terminology that gets used, et cetera. And then our last session is going to be held February 28th. We hope that you will join us for that. We're going to have a great session where we're going to talk about how patient groups are impacted and how they can become engaged in the process. And we have a number of our groups that are going to be joining us to talk about what they're doing and what's actively going on right now in their organizations. So as I said, today we're going to talk about basic terminology when we talk about payment models, and we're going to talk about the different types of alternative payment models. We're going to talk a little bit about, we talked about value going to value from volume last time, and we're going to talk a little bit about how value-based payment has a role in that today. And we're going to also have 2 guest speakers at the end of the session who will talk a little bit more about their own experiences. So a little refresher from our first session, what is an alternative payment model? It's a payment approach that gives incentive payments for providing high quality and cost-efficient care. We talked more about that in the first session. We're going to dig a little deeper in today's program. So let's talk about incentives, the role of incentives and quality measurement. So we've got, as we talked about last time, that quality measures play a role in these alternative payment programs because the clinicians and organizations must report on sets of quality measures and other kinds of measures, and they get an incentive payment often for how well they do on those quality measures. But this is something that's been evolving over time. We didn't just jump into something like that. We initially began with public reporting. So when organizations were required to report their information, and it would be made public based on the kind of information that was provided, then we didn't see anyone being paid for that, and they weren't getting paid for reporting, they weren't getting paid for their performance. Instead, their incentive was to get recognition for reporting. So you might see them could be a marketing effort. They might use it as we're rated as highest in our community. And it was really that kind of recognition that was the incentive for doing it. Next, after that, we went to pay for reporting. And this is where some programs got put into place by CMS, where they actually were paying organizations to report their data. And they would get paid a bonus payment initially to report the data, and eventually that was phased out. And instead it was, you didn't get a bonus payment for reporting. Instead, you got a penalty if you didn't report. So it was a reporting effort. You see the check mark there for the incentive was for reporting, the pay was for reporting, but it didn't matter what you scored. You weren't getting paid for how well you scored. That wasn't counting at the time. It was simply getting paid for reporting. Then we went into a phase of pay for performance, and that's where you have to report, and you can get paid for reporting, but now you also get scored, and you get paid for the score. So again, the incentive was to get people to report, and the incentive is to get them to perform well. But many programs are now even phasing that part out, and they're saying you're going to get your regular payment if you report, but you have to score well in order to get your payment, and you get a penalty if you score poorly. So these are all different iterations of getting us to a pay for performance or pay for reporting system. So again, pay for performance is also known as value-based payment. So there are many different types of alternative payment models out there, and we're just going to review a few of them. We are familiar with bundled payments. That's been going on for quite some time, and it means that you're going to get a payment for providing a bundle of services. So, for example, if a patient has a heart attack, paid for the emergency room visit, the hospitalization, and some of the post-hospitalization care, but it's all bundled into one payment because that's what that payer pays for that type of care or that type of episode of care as an episode-based payment. Again, there would be some requirements that quality of services would have to be associated with this, and that the bundle would also would be for a package of services with one payment, but with the expectation that there'd be a certain level of care. Capitated payment or population-based payment, meaning that you get a payment to take care of a population of patients. And so you provide all of the services that are required for them under that capitated payment or that payment per person that you'd be getting. And there aren't, you don't get paid by the volume of services. You get paid for taking care of that person in entirety, all the services that are offered to that person. Another type is accountable care organizations. And very often accountable care organizations are involved in shared savings programs. Accountable care organizations, this happens when a group of providers, so for example, in a community, a hospital, a network of physicians, a laboratory, and maybe a pharmacy or a group of pharmacies might all partner together to provide services to a group of patients like Medicare patients. And they do that providing those services as a package. And the understanding is that if they can lower costs, if they can provide services at a lower cost than the benchmark cost for those services, maybe benchmarked on the previous year's cost or the last several years of cost, if they can do it better, they get to share a portion of the savings that were achieved. So if the cost for those patients was $1 million last year, and they can get that cost down to $750,000, then they get to share some of the $250,000 that was saved. And an example is the Medicare Shared Savings Program. So again, we're talking about value-based payment, which rewards healthcare providers with incentive payments for the quality of the care that they give to the people that they're responsible for caring for, their beneficiaries. And so we're going to talk a little bit more about what's going on with the CMS Quality Payment Program, which is turning to value-based payment. As we talked about last week, when the SGR was replaced and the macro legislation was instituted, it turned the program, the CMS Quality Patient Program, into a new program that offers 2 tracks for physicians to be paid in the Medicare payment program. And this is moving clinicians from being paid according to the fee-for-service model to the value-based payment model. So when we talk about these, we're talking about the Merit-Based Incentive Payment System, MIPS, and the Advanced Alternative Payment Models, APMs. We're going to talk a little bit more about these and get into a little bit more detail about how they are value-based payment programs. So in the MIPS is scored based on a 100-point system. And in 2018, the scoring is broken up into this distribution among the 4 categories for determining payment. Clinicians and organizations have to submit information on quality of services, resource use and cost, advanced care information, and then quality improvement activities or clinical practice improvement activities. You see here we have a distribution of 50% for quality. We have 10% for resource and cost use. This is new. This was 0% last year in 2017, and it got turned into 10% for 2018, and that's partly because the quality component got moved from being 60% down to 50%. Advanced care information went to 25%, and improvement activities is at 15%. So what happens is the physician gets scored, and based on that scoring, they can earn up to a 5% bonus or a decrease, a penalty of up to 5% from what they would have been paid. So it takes what they would have been paid and gives them an additional bonus, or they lose money based upon how they scored. And the payment is based upon the percent score that they achieve. So this is the merit-based merit-based incentive payment system, which is called MIPS. The alternative to this that a clinician or a doctor's office can choose is the advanced alternative payment model. And this is again, value-based payment. It offers more incentive, so they can earn more, but there is more risk involved in this type of system. It requires that the doctor's office has to have the use of a certified, and there's electronic medical record, and the spell checker got us. It's supposed to be an EHR, not an HER. So it's an electronic, the electronic health records. Payment based on quality measures, similar to MIPS, so they use the same quality measures. They are required that they must be a medical home through the medical home payment system that CMS has in place, and with the qualifications that they have to follow, or it requires that the participating alternative payment model, the alternative APM entity, has to meet certain requirements. It has to have certain volume of 25% Medicare Part B payments or 20% of Medicare payments. So it has to commit to a minimum volume of Medicare patients who they're caring for, and they bear more than a nominal amount of financial risk for their monetary losses. So what happens here is that the reporting data gets scored, and a higher score means that they receive their payment incentives, or a lower score means no payment incentive at all. So it could mean that they have a penalty. Again, this would be on top of what they would be getting if they were in a MIPS plan, in a MIPS system, and it means that if they could achieve even greater than the 5%, they could get even more if they also realize shared savings, as we were talking about in one of the previous slides. So the advanced alternative payment models gives the clinician an opportunity to to make more of a bonus, to actually have more incentive, but it also requires them to take on more risk. One of the things that's important to realize is that very often CMS, in terms of what it does for Medicare and Medicaid, can be a real leader in what's happening in healthcare, and they can lead the direction of where healthcare is going. So because Medicare, Medicaid, and the CHIP program are such large programs, they have vast enrollment, they have a wide range of populations that are involved, and they've had a lot of history over the last 15 to 20 years with paper reporting programs, that P4R, paper reporting programs. They've been leading the way on a lot of the value-based programs and leading the way toward more value-based payments. And that spills over into the private sector. And so the private sector has been working through more incentive initiatives, giving bonuses to providers for meeting certain kinds of incentives, for using these kinds of programs for marketing purposes, for an organization to be able to market itself as being of higher quality than its competitors in a particular area. And they can also use these programs for cost containment within the organization. We're going to hear a little bit more about that from one of our guest speakers today, but it's important to keep in mind that this isn't what's just happening in the public programs. It's not just happening in Medicare and in Medicaid, but we're starting to see that spill over into the private sector, and we should be seeing that more and more in the future. So I want to take a minute to introduce our guest speakers. We have Greg Jones joining us from Aetna, and we have Elizabeth Franklin joining us from the cancer support community. And now I'm going to turn this over to Greg, who's going to talk about alternative payment models and value-based payment from the private payer perspective.
Hi, thank you very much. Good afternoon, everyone. This is Greg Jones. I'm with Aetna. I'm in the government affairs shop on the policy team based in CMS, and I've been with Aetna for about 3 years. And I came to Aetna from CMS, where I worked for many, many years, and as well as HHS for a total of 15 years in different parts of both the agency and the department. So I thought one of the things I thought I would point out, I thought the initial overview was really good, is that one of the things I think that's always important to sort of take into account when you're looking at this is, especially in a company like Aetna, where Medicare Advantage in particular is a big part of our business strategy. I think, this is definitely an area where we are looking to grow our business. And when you look at Medicare Advantage and compare it to fee-for-service, one of the things, people talk about capitated payment, value-based payment. There's a lot of work, obviously, going on in the fee-for-service space over the past several years, and this was even pre-MACRA, with different payment models coming out of the Innovation Center, a lot of the things that are included in MACRA. But on the MA side of the house, and that's fee-for-service, but on the MA side of the house, people, when they talk about capitated payment, I think often get a little bit confused or conflate the fact that CMS is paying an MA plan a capitated payment to actually take on, to be the insurer for, at this point, almost 20 million Medicare beneficiaries. And then underneath that, MA plans are paying providers, hospitals, physicians, DME, you name it, every single type of provider that would be in fee-for-service under a payment arrangement in order for them to render services to MA enrollees. And what I've learned, I think, since I've been here is, that is done in many different ways. And, insurance companies like CMS, their strategy for partnering with providers, the way they pay for providers, the way they look at quality, the way they look at financial risk, the way, they interact in terms of, incentives for the use of electronic health records, that is evolving very quickly. And, as it was mentioned, Medicare is just the Medicare program as a whole and the Medicare fee-for-service is, such a large and significant program and healthcare program in our country. So it definitely impacts, what goes on in even a company like Aetna within our MA program, as well as even our commercial space, and then even in Medicaid, because we are also a provider of Medicaid managed care, and even within that line of business, we are entering into a lot of different value-based payment arrangements. So the slides you have here, I know there's a lot on both slides. I'm happy to send these out as separate documents. It actually comes directly from some two-pagers, two different, 2-pagers, 1-pagers, depending on how you look at it, documents that we've kind of done that are publicly available about kind of what we're doing in this space. And if it's easier to have these as standalone documents, I'm happy to have those be shared with everyone after this call. But so I thought I would kind of just walk through them a little bit. So I think I covered a lot in terms of kind of our perspective, our approach, how we're kind of looking at this in Medicaid and MA in terms of relative to fee-for-service. But I think one of the things that I think is important is at the bottom of the first slide, there's a little diagram there, and I think it really kind of talks about our approach. And one of the things we have learned through our experience is that, we obviously have a financial incentive for our relationship with providers to include a value-based payment arrangement of some type, whether that be a bundled payment, whether it be a capitated payment, whether it be, a fee-for-service payment as an underlayer with a pay-for-performance component on top, because we're trying, just like CMS, to create more efficiency in the system, to get the most value out of those services that are rendered to our members. But I think one of the things we've learned is that, we deal with very large and sophisticated health systems. We could be in a partnership with some, an entity like Emory University in Atlanta as well as mom and, just standalone physician practices, as well as maybe group physician practices that have 5 physicians. We obviously have an oncology network. I mean, we deal with every type of provider. And so one of the things we've learned is that we need to kind of be very realistic about what their capabilities are in terms of these arrangements. So I think what this really shows is that what we are trying to meet them where they are, is what they often call it. Our business people often call it, who actually negotiate these arrangements with providers. And so some of these relationships evolve. So we may just start initially with, for someone who we've been paying for many years on a fee-for-service basis, say, we're just going to add a pay-for-performance, like a one-sided risk arrangement, and if you do X, Y, and Z, for example, report some quality metrics, we'll give you this payment. And that, that may be just a start, and maybe that's something to do with like a smaller, less sophisticated physician practice. But then over time, as we look at the data that's coming in and how things are going and looking at the health outcomes of the beneficiaries or enrollees who are being treated by those physicians, then we figure out ways to calibrate that and sort of evolve it over time. And obviously, the arrangements that we participate in with providers is going to be a little different than hospitals, and it's going to vary. So I thought that was just something I would highlight. And then if we go to the next slide, I think there we just have like a list of some of our, our sort of things that we're looking at in the policy space. But one of the things I thought would be interesting for this group is talk a little bit about some examples of arrangements that we have in place already. So, for example, one of the arrangements highlighted here is a partnership we have with Central Ohio Primary Care. This is a very large physician-owned primary care practice in the United States. It has over 350 physicians in 57 locations throughout Ohio. We have a very deep and engaged relationship with them. What we're doing actually as part of that arrangement is, we're paying them on a per patient per month basis to care for our members. But on top of that, what we said is, we really believe in your model. You guys have a great practice. You're doing a lot of good things in the community, especially with regard to how you're taking care of our members, that we're actually investing in their infrastructure. So, for example, they can have a 24/7 call center staffed by a nurse. They can invest in electronic health records. They can do house calls, because all of those things, if they have the capabilities to do those, at the end of the day, they help our members, and they help us. So it's really interesting, because one of the things we've learned is when you're working with physician practices, often than not, what they need is capital, honestly, to invest in these kinds of things that can actually help them work better with their members, hence our members, and then improve health outcomes. So I think things like the 24-hour call center in this place in Central Ohio, and I've actually met with some of these folks, they do house calls. And that is like so beneficial, especially for folks who are chronically ill or homebound or having transportation issues, or kind of, they just don't have ready access to transportation. So that is just so valuable. Another model that's highlighted here that folks who, especially that live in the D.C. area, may be familiar with is Innovation Health. It's obviously a very large health system operating in Northern Virginia. Very different model. What we have with Innovation Health, as well as several other entities at this stage, are what we call joint ventures. So with Innovation Health, many of you actually probably see some of their advertising and their commercials. They are a health insurer, and then we are actually partnering with them to kind of like be the backroom operation, really, to help them be an insurer in the Northern Virginia market. So that is a pretty different model. It started out, they were one of our big providers, and then, they decided that they wanted to become an insurance company and get into this business, but they don't have, like, all the expertise and the tools available to them, so we partnered up. And we're an active part of that joint venture. And they actually so it started out in the commercial business, and we just added Medicare Advantage to that arrangement just in January of this year. So very different, obviously, compared to Central Ohio primary care, completely different type of arrangement, completely different type of model, especially given that it's a very large health system serving one of the biggest metropolitan areas in the country. And then another one that we are very proud of and have a long-standing relationship with is an entity called Banner Health. It's in Phoenix, Arizona. This is a very successful accountable care organization partnership that we've had in place for many years. One of the things that we're really looking to do as part of that is really also just improve the overall consumer experience, because we want our members, when they're accessing healthcare, whether it's through a hospital or through a physician, a lab work, whatever it is, we want them to have like a seamless experience. I mean, I think all of us in healthcare are really trying to, create like what I sometimes refer to as like the Amazon experience, but in, the delivery system. We've all faced those challenges. So we are actually looking at like ways when we're partnering with entities to actually bring that sort of component to light, figure out ways to remove barriers, and actually try to measure it over time and make it more seamless. But, so as you can see there, through our measurement, we've had 15% better retention in that particular model. So that actually has been a good thing for us. We've actually been able to save almost $10 million in shared savings. We've been able to 24% reduction in avoidable surgical admissions, and 11.5% overall reduction in medical costs. So all good things that are like coming from that partnership. So I think those are just some examples I thought I'd highlight. Happy to kind of stop now, pass it on to my counterpart who's going to do their presentation. I'm happy to answer questions when we get to the Q&A.
Thanks, Greg. Appreciate that. Next up, we have Elizabeth Franklin from the Cancer Support Community, and I'll turn it over to Elizabeth for a little bit about herself and then the presentation.
Great. Thank you, Jason and Eleanor. I appreciate you asking me to speak. I'm going to pivot a little bit from the broader models to one very specific model, which is the oncology care model. I know some folks on the phone will be familiar with it, but I'm going to do a little bit of level setting in terms of what the OCM is, and then I'm going to talk predominantly sort of a preview of a research project that we're working on at the Cancer Support Community and what we hope to get out of that. So just in terms of level setting for folks who aren't as familiar with the oncology care model, so it is an advanced APM that was put in place by CMMI. It's important because it covers Medicare patients, and half of newly diagnosed patients are over the age of 65, making Medicare the single largest payer of oncology care. OCM practices are across the country. There's almost 200 practices taking part in this voluntary program, and ultimately it's geared towards more high-quality, highly coordinated care, and I'll talk about what that should encompass and what that's going to look like. Basically, the OCM is looking to gear better care, more high-quality care at the same or lower price. And as you can see at the bottom of this slide, it would reimburse practices $160 monthly per patient for a care management fee. And there are 4 parts to sort of the OCM enhanced services. The first would be a 24/7 patient access to appropriate clinicians with real-time access to their medical records, electronic medical records, core functions of patient navigation, and that's why you see the care management fee. So things like patient navigation are not reimbursable, and so those enhanced services that kind of wrap around the patient are the reasons why that extra fee is there. A documented care plan that contains 13 components of the Institute of Medicine care management plan, and ultimately treatment with therapies that are consistent with nationally recognized clinical guidelines, and then explanation of deviations if they don't adhere to those guidelines. So this gives you a very sort of basic overview of the oncology care model, and again, it's voluntary at this point, and we just saw the first kind of introductory report into the OCM model, which I will talk about, but we're approaching the point where practices have to decide if they're going to continue in the model, take on more risk, not just the cost savings, but also the risk of running the OCM practice, so the losses as well. So next slide, please. And I talked about this. These are the 4 kind of enhanced services that OCM practices have to adhere to. And the reason why the cancer support community, for those that don't know, we are the largest provider of social and emotional support services across the nation. We have 47 affiliates, brick-and-mortar locations where patients can actually come in and receive services, counseling, support groups, yoga, cooking classes, any of the non-medical services that they need. So we were really interested in these core functions of patient navigation and the components of the care management plan. Is the OCM not only saving money and improving kind of standard health outcomes, so is it improving overall survival and contributing to patient health outcomes, but also, what do patients really care about? You know, in addition to survival, patients may care that it has saved them out-of-pocket costs, that it has prevented them from going into the emergency room, that it has lessened their distress level. Those are the kinds of things that we're really interested in, which I'll talk about the project that we're going to be doing on the OCM in just a moment. So we can move to the next slide, please. So as I mentioned, they just came out with the first sort of introductory report. The actual cost and performance of the practices will be coming out hopefully later this month. But the overarching goal is to examine the impact of the OCM on outcomes such as episode utilization and expenditures. We actually are seeing on an average basis, on the per episode average basis, that utilization and related costs were actually higher. Right now, you can see the average there is $27,400 for OCM practices and $26,200 for the comparison group. And so far, it appears to be significant variation in utilization and cost by cancer bundle. So different types of cancer are proving to be more expensive, and beneficiary characteristics. And this is really important to pay attention to because we want to make sure that in these different payment models, that practices that are supporting more high-need patients are not being dinged as a result of that. So being sensitive to the different beneficiary characteristics. And as I mentioned, practices may voluntarily take two-sided risk. They could have started doing this in January of 2017, and they will be required to move to two-sided risk around the summer of 2019. The challenge with that is that not only do you benefit from shared savings, which is what's going on right now, but then you also potentially are on the hook for the losses as well. So that can be really scary for practices to have to make that decision. So it's incredibly important that not only we have this summary information that's available if you go to the CMS website right now, but that the practices actually receive their specific information so that they can make an informed decision about whether to continue participating in the OCM. Next slide. So as I mentioned, the cancer support community is particularly interested in the patient experience. We really want to understand, do patients know that they are in oncology care model practices? Are they receiving the full list of enhanced services? And then if they are receiving those enhanced services, how does that compare to non-OCM practices? So we really want to understand from a patient perspective, is participation in an OCM practice worth it for them? Are they getting something tangible out of it? And so we are working with our advisory board right now, working with partners to recruit 5 or 6 OCM practices and 2 or 3 non-OCM practices. And we're going to be holding focus groups to talk to them about what's most important, about their experience with the program. And then we'll be fielding a broader survey with those patients to really get to the heart of what's going on, what their experience has been. And I'll talk about the enhanced services that we're really interested in focusing on. So go to the next slide, please. So again, what does that patient experience look like? And we took the core enhanced services that are a part of the OCM, and those are serving as the foundation for our focus group guide, which will ultimately inform our survey. So first, the experience in the practice. What is the patient's relationship like with the healthcare team? Are they able to ask questions, engage in discussion? You know, as everyone on this call is very well aware, we've moved from a physician prescribes treatment, patient says okay, and just moves forward, and we're really into a shared decision-making model. And so was the patient able to ask questions about what do those treatment guidelines look like? What is the patient's personal treatment goals? You know, is it incredibly important for them to have treatment that, you know, allows them to maintain their hair? Would fatigue or nausea be really important to them? Would sexuality and fertility be really important? And so walking through those personal treatment goals and understanding from the patient's perspective what's most important to them. And again, the benefits and side effects, the costs, it's incredibly important for patients to understand what this is going to cost them out of pocket. And then ultimately working with their care team on that personal treatment plan. So we want to find out if the patient felt like they were an equal partner in the care team and that they could have these conversations, which would ultimately lead to a treatment plan that was right for them. So we'll start there, and on the next slide, you'll see that we'll move on to the experience outside of the practice. One of the things that was most important in terms of the ways in which OCM practices function are, is the patient comfortable contacting the practice after hours? If something was wrong, I think one of the most common ways in which patients access or need to access their doctor is they're having some sort of side effect or something's going on and they're curious if they need to go to the emergency room. And so there should be a 24/7 phone line set up so they can contact a member of the healthcare team, ask questions, hopefully keep them out of the emergency room if they don't need to be in the emergency room. But if they do, then the practice should be following up with the patient after that visit to find out what happened, why they were there, if there's a way to avoid it in the future, and if that was the right move for them, how the practice can be supportive of them after the fact. So we'll be following up to ask about their experience sort of after hours, on weekends, outside of the normal working hours of the practice. Next slide, please. As I mentioned before, we are particularly interested in the patient navigation support. So just like in the Commission on Cancer guidelines, patient navigation is seen as an activity or a function. It's not, they don't have to necessarily hire patient navigators or social workers. Many will have these folks on staff, and so we want to understand what was the interaction like with the person who is tasked with patient navigation duties, asking questions about things like appointment scheduling, care coordination, and logistical concerns. Of course, we are particularly interested in understanding emotional distress. Was the patient asked about their distress level? Was their distress or their depression or their anxiety measured in some way? And then were they able to be connected to resources if they did screen positive for any of those challenges? And then also palliative care. If they were experiencing pain or if they needed to be connected to palliative care services for any reason, did that happen? And what was their experience with palliative care? Go to the next slide. And so ultimately, we're launching this project right now. We've recruited our sites. We will be working with them to start the focus groups, and then we will be launching the survey. So hopefully I will come back to you later this year to give you the results of that and to tell you not only is this practice model and this reimbursement model saving money and improving care in terms of the traditional outcomes that we focus on as a healthcare system, but also are we able to measure and focus on the other things that patients really care about that make a difference in their cancer journey. So with that, I will turn it back to Jason and Eleanor, and I appreciate you inviting me to speak.
Thank you, Elizabeth, and we'll certainly look forward to checking in with you on that work as we move forward. Now I think we just want to open it up to any questions you may have for Greg, Elizabeth, or Eleanor. Feel free to utilize the chat feature if you want, or all the lines are unmuted, so I'll sort of just open it up.
Yeah, hi, this is Gail Hunt, National Alliance for Caregiving.
Hey, Gail.
We've done, you talked a lot about the patient, but nothing, as far as I could tell, about the family caregiver. And we've done research around caregivers of people with cancer and know that it can have an incredible impact on the family. And I would just suggest that when you're doing your survey and looking at the impact on the patient in a whole variety of ways, that you also think about the family and measure the impact on the family caregiver and how that plays out financially as well as emotionally and physically.
Thanks, Gail. I completely agree with you, and I did not do a great job of communicating the importance of the caregiver during this call. CSC is very focused on the caregiver. We've actually been in contact with your group recently, and we will definitely be exploring the impact of sort of the OCM practice on the loved one, the caregiver, but I appreciate you bringing it up. It's an incredibly important point.
Thanks.
Hi, this is Larry Lamott with the Immune Deficiency Foundation. I have just a couple of questions. In a general way, for those communities that have rare diseases, how does this really fit into, how does the value-based healthcare that you talked about fit with rare diseases? And then I have a second question that I'll get to after the first one, if that's okay with everybody. I guess this is for Eleanor or Mr. Brooks.
Greg, do you have anything on that one? Do you want to start?
Sure. I mean, this is Greg Jones with Aetna. I mean, thank you for the question. I mean, I think I would say one of the, in terms of working with our members who are dealing with an unfortunate rare disease, one of the things we leverage a lot in those circumstances are nurse case managers. We have a lot of nurse case managers within Aetna, and we're actually building out that functionality in a much more robust way than it was previously. And essentially what they do is really help and to improve the patient's journey. So if someone was had cancer or another rare disease, our nurse case managers would actually be working directly with them by phone. We're trying to actually get them in the home and more, or working with the patient at a place that's convenient for them to figure out what barriers they're facing in terms of accessing care. In terms of, for example, are they, do they need to see a specialist that's 2 hours from their home? Is there some way we can find a way that a physician or a hospital that's closer, working through all of those issues to really improve their journey and, break down those barriers. So I'd say that was, and that's something we look to do in all of our arrangements, whether it's employer insurance, Medicaid. Like in Medicaid, for example, we do a lot even with behavioral health as well.
My second question is really for you too. Is how do you recognize, these value-based models dealing with reimbursement that we've been talking about, with the other policies from the payers have, which do the exact opposite by that are being designed to cut usage. And I could give you an example is that in our space with people with primary immunodeficiency diseases, that the reimbursement and value, you're being judged on success, et cetera, and yet, the only treatment for those with antibody deficient is having infusions, and yet your company's policy is the lowest cost for a product, the lowest immunoglobulin product available, and that may not be the right thing for a physician to prescribe, and yet who will be penalized if the outcomes aren't as good. So I'm just trying it's one thing to talk about value-based reimbursement, but it's the other kinds of policies that payers have that are going and moving in a different direction and just dealing with just cost. And I'm trying to figure out how you reconcile that so that you get a decent patient-centered outcome. Because most people, we don't have, the kind of oncology model because we're dealing with rare, less than 250,000 people who have a primary immune deficiency. Actually, it's even smaller than that. But anyway, how do you reconcile that?
Sure. That's a great question. And, first of all, I'll start by saying I'm not a physician, but, as an insured, we obviously employ a lot of physicians, and they help develop what I would call our coverage guidelines and policies, because I think that's kind of what you're really getting at there is like what we are paying for and under what circumstances, depending on someone's diagnosis from a physician. And the conversation we're having today is really about value-based payment. I think that's a great question to figure out how do those intersect and work together. I mean, I would say at a high level, I would say, and if you listen to our CEO speak, our goal as a company is really to try to move the healthcare system in a direction that's more efficient. Approach the triple aim. I came from CMS where I had the opportunity to work for Don Berwick for several years during his tenure there, who's kind of developed the whole triple aim concept. And I think we're all trying to get to the same place. And I think that, through doing like a very patient-centered, having a very patient-centered model with the use of these case managers that I'm talking about is sometimes I think where we'd like to get is you have a patient, you have this policy and a procedure right in front of you, and then you actually, when you start to apply that particular case, it just may not make sense, and it may make sense to do something else. And we're trying to get to a place where we're able to kind of operationalize this at that level, where an exception can be made or something like that. But obviously, we're operating in a complex environment with like a legal and regulatory framework in terms of coverage. But I'd say we do want to get there. And I know that maybe not be the best answer you're looking for, because not a lot of the coverage policy may be fully integrated with the payment policy in terms of how we're paying a hospital or physician, because those are things that have to kind of be dealt with, I think, really on a case-by-case basis.
I also want to add, Larry, I think one of the things that we're talking about here in terms of getting to value-based payment gets to the heart of what you're talking about. So under fee-for-service, the incentive is to ratchet those costs down so that they're as low as possible when you're taking care of that individual. But under a value-based payment system, because quality metrics have to be met, and some of those other things balance out the decisions, it may very well be that a physician who's making those choices, who's taken on that risk, might make different choices for the higher cost items because they know that they have to meet those quality metrics also. And I think that that's the purpose of a value-based system, and obviously we're just not there yet. But I guess my question would be to Greg, how do we know that those, especially for something like a rare condition as Larry's raising, but for other conditions too, how do we get to measures of the quality and satisfaction that patients have with their care so that we do know that those choices are being made based upon meeting the quality part of it, meeting that quality component of it, and not just in ratcheting down those costs. Do you have any thoughts on that?
Yeah, no, I think one of the best ways to honestly get at that is to kind of look at what you're doing figuring out what's working, what's not, and making improvements as you move forward. And like, for example, you know, when I talked a little bit about the evolution that we're going through with some of these health systems, I mean, obviously, Aetna's been around a long time, so we have long-standing relationships with many, especially with the health systems, the hospitals, but then obviously lots and lots of physicians that maybe have been in the Aetna network caring for like our commercial members for 30 years at this point. So we have the data. We, you know, more and more over the past few years, like quality reporting is being integrated into that. And that also includes measures like related to patient satisfaction and member experience. So I think we need to build that into the system. We need to be looking at what's working and what's not working, and then change as we kind of move forward.
Thanks, Greg. Any other questions from anyone on the line for Greg, Elizabeth, Eleanor? All right. Well, not hearing too much. Do want to highlight our last webinar of this series, which will be part 3, on Wednesday, February 28th from 3:30 to 4:30 p.m. Eastern, 12:30 to 1:30 Pacific. You will receive, if you haven't already, a calendar invite just for being on this webinar for that webinar. And yes, the recording of our previous webinar is already available on our website. This webinar, if you want to share with any colleagues, will be on our website early next week. And as you see, part 3, how patient groups are impacted and can be engaged in the process, and Eleanor touched on that. We're going to dive a little bit deeper and really focus on patient organizations, hear from a few different patient organization speakers, and see how we can improve that process. So with that, I just want to thank everyone, including Amgen, the sponsor of this series. And Eleanor, any final thoughts?
Just want to thank our speakers. Thank you very much, Greg and Elizabeth. Thanks for joining us.